very good morning to all. I am Dr. Natasha Gambhir, Professor, Department of Pediatric and Preventive Dentistry. Today I will be presenting my lecture on the topic Pitt and Fisher sealants. I will be covering my lecture under the following heads: introduction, definition, history, types of sealants, their properties, recent advances, clinical application, and finally I will conclude it. Dental caries, as we all know, is a multifactorial disease caused by alteration in the composition of the bacterial biofilm, leading to an imbalance between the demineralization and remineralization processes, and is manifested by the formation of carious lesions in primary and permanent dentitions. More effective measures are necessary to protect Pitt and Fishers, and one of these measures includes the Pitt and Fisher sealants. Sealant application is a preventive, conservative approach involving the introduction of sealants into the pits and fissures of caries-prone teeth. The sealant then bounds to the tooth micromechanically. Pitt, according to Ash in the year 1993, was defined as a small pinpoint depression located at the junction of developmental grooves or at terminals of those grooves. Fissures, according to Orban in the year 1954, are defined as deep clefts between adjoining cusps. Types of occlusal fissures. This classification was given by Nagno in the year 1960. They include the V type, which is wide at the top and gradually narrowing towards the bottom, tends to be self-cleaning. They are shallow and wide, somewhat caries resistant, and non-invasive technique is recommended to treat them. This is seen in 34% of the population. U type, they consist 14% of fissures and consists of similar width, shallow and wide. They tend to be self-cleaning and somewhat caries resistant, and non-invasive technique is recommended. The I type is extremely narrow slit, 19% is seen. It is deep, narrow and quite constricted, resembling a bottleneck. Caries susceptible and they require invasive technique. The IK type is seen as narrow slit associated with a larger shape at the bottom. This is seen in 26% of the cases. It requires invasive technique and they are very susceptible to caries. Last is the inverted Y type, which is seen in 5 to 10% of the population. Now, what are Pitt and Fisher sealants? According to Simoson RG in the year 1978, this term was used to describe a material that is introduced into the occlusal pits and fissures of caries susceptible teeth, thus forming a micromechanically bonded protective layer cutting access of caries producing bacteria from their source of nutrients. Fisher sealant by Welbry in the year 2003 was defined as a material that is placed in the pit and fissures of teeth in order to prevent or arrest the development of caries. A little bit about the history of the Pitt and Fisher sealants. In the past, several attempts were made to protect pits and fissures from becoming carious. This involved the widening of fissures or so-called fissurotomy to transform deep fissures into cleansable ones. Another method used was to treat pits and fissures with ammonical silver nitrate. Now, what are the ideal requirements of a Pitt and Fisher sealant? First, a viscosity allowing penetration into deep and narrow fissures even in the maxillary teeth. They should have an adequate working time. They should cure rapidly. They should have good and prolonged adhesion to the enamel. They should have low sorption and solubility. They should resist wear. They should cause minimal irritation to the tissues, and they should have a karyostatic action. Indications. Newly erupted both primary molars and permanent bicuspids, stained pits and fissures with minimum decalcification. Tooth should have erupted less than 4 years ago. A deep or a regular fissure, fossa or pit is present. An intact occlusal surface is present where the contralateral tooth surface is carious or restored. Patients with incipient caries. Patients who have sufficiently erupted permanent teeth with susceptible pits and fissures. The contraindications include uncooperative behavior, A large restoration is present on the occlusal surface. Well established cavitated carious lesion and proximal caries. If pits and fissures are self-cleansing, life expectancy of primary tooth is very less. When a patient is allergic to sealant material, and pit and fissure that has remained caries free for 4 years or longer. There are various types of sealants that are available. According to Michel and Gordon in the year 1990, they were classified as resin-based sealants, which are composed of urethane, dimethacrylate or bisphenol monomers, glass ionomer sealants, which are composed of fluoroaluminosilicate glass powder and an aqueous-based polyacrylic acid solution. Now these resin-based sealants, they are classified into 4 generations according to the method of polymerization. The first generation is polymerized by the action of ultraviolet rays, for example the Nuva seal. The second generation is autopolymerizing resin-based sealant. Tertiary amine is added to it as one of the components which acts as the activator here. Third generation sealants, they are visibly light cured, and this resin gets activated by photoinitiators sensitive to visible light in the wavelength region of around 470 nanometer. The fourth generation ones are fluoride resin based sealants. This is the product resulting from adding fluoride releasing particles to this to inhibit the development of caries. The disadvantage of resin-based sealers are that polymerization shrinkage occurs, potentially resulting in micro leakage, which allows saliva and bacteria to penetrate the occlusal barrier. Stronger biofilm accumulation seems to occur on resin-based materials. The GIC-based sealers, conventional glass ionomer material has also been used as a pit and fissure sealant. It bonds chemically to enamel and dentine through an acid-base reaction between an aqueous-based polyacrylic acid solution and fluoroaluminosilicate glass powder. Glass ionomer-based sealants, these are resin-modified glass ionomer, and these also have been used as pit and fissure sealants. The setting reaction of this type of sealant is initiated by the photoactivation of the resin component, followed by the acid-based reaction of the ionomer component. It has improved physical characteristics like less sensitivity to water and a longer working time compared to the conventional glass ionomer. The advantage of these are continuous fluoride release and the fluoride recharging ability, which is the most important advantage. It also has a preventive effect which may even last after the visible loss of the sealant material, as some part of the sealant may remain in the deep pits and fissures. It is moisture friendly and easier to place and is not vulnerable to moisture compared to the hydrophobic resin based sealants. If it is impossible to isolate the teeth, for example in the case of incompliant patients or children or teeth in eruption, glass ionomer sealant material should be preferred. Disadvantage: the fracture of the material can occur due to its reduced ability to withstand occlusal forces. It is considered a provisional sealant and has to be replaced with a resin-based sealant when better isolation is possible. Various recent advances have been seen in case of pit and fissure sealants. Nano composites have been introduced as pit and fissure sealants. Fillers of nano-sized particles help to improve their strength, luster and resists water. Silver particles are antibacterial agents when used in fillers that can retard bacterial growth and reduce tooth decay. It is envisaged that in the longer term, biomimetic approaches will be useful. Singh S. et al. In the year 2011 stated that nano composites were found to be an excellent dental material for penetration in deep pits and fissures, though it exhibits mild micro leakage. Enamel deproteinization is also a recent advantage. Espinoza et al. In the year 2008 conducted a study in which 5.2% sodium hypochlorite was used as a deproteinizing agent before phosphoric acid etching. It showed that prior deprotonization of by sodium hypochlorite significantly doubles the enamel's retentive surface to 94.47%. This technique seemed effective in removing organic elements from the enamel structure as well as the acquired pellicle, thereby conserving the tooth structure and improving the adhesive properties. Enamel deprotonization and intermediate bonding in the retention of Pitt and Fisher sealants is also one of the methods. Enamel deprotonization along with the use of intermediate bonding layer significantly enhances the retention of Pitt and Fisher sealants in terms of enhanced marginal integrity, decreased marginal discoloration and preserving the anatomical form as confirmed by the studies done by Reshika et al. In the year 2018. Another advancement is the polyacid modified resin based sealants. The polyacid modified resin based composite material, which is also referred to as Compomer, has been used as a Pitt and Fisher sealant. It combines the advantageous properties of a visible light polymerized resin based sealant with the fluoride releasing properties of the glass ionomer sealant. A polyacid modified resin based sealant has a better adhesion property to enamel and to dentine and is also less water soluble compared to the glass ionomer sealant materials and less technique sensitive compared to the resin based sealant. Another advancement can be seen as the color changing sealants. In March 1977, the first colored sealant was introduced to the market by 3M and it was called the concise white sealant. It is easier to see the sealant during application and it is faster and easier to assess with a white sealant than a clear sealant at a later time interval. Helioseal material, which changes the color from clear to green when exposed to visible light, has some clinical utility, particularly on subsequent follow-ups and examinations. Another advancement includes the hydrophobic and hydrophilic Pitt and Fisher sealants. Hydrophilic Pitt and Fisher sealants, they are activated in the presence of water. They have filler particles like carbon fiber, aluminum powder, calcium carbonate, silica clay. They do not have bis GMA or bisphenol A. Hydrophobic Pitt and Fisher sealants, these are the traditional sealants that do not adhere to the tooth surface in the presence of water as they are composed of bis GMA. What are the clinical applications? Now, to start with, the armamentarium that is required is our diagnostic agents, the mouth mirror, the probe, the tweezer. We need an air water syringe system. We will need an excavator tip. We need cotton rolls, cotton pellets, articulating paper, curing light is required. We require a handpiece. We require a Dept dish with pumice. Starting with the preparation of the tooth, the step 1 is to isolate the tooth. This is done by the placement of a rubber dam and use of cotton rolls and saliva absorbers to achieve complete isolation of the tooth. Here I would like to emphasize on the fact that complete isolation of the tooth is required for the Pitt and Fisher sealant to actually stay and adhere to the tooth. The step 2 includes the prophylaxis of the tooth or the teeth involved. Prophylaxis should be carried out using pumice slurry applied with a rubber cup or a pointed bristle brush and rinse the tooth well with air water spray. Step 3 is the etching of the tooth for a resin based sealant. Acid etching may be enough for cleaning of a tooth surface. 37% phosphoric acid is applied directly with special application tips or a small disposable brush. This should be applied to all susceptible pits and fissures and it should extend up to the cuspal inclines. Etching is done for 15 seconds in case of permanent molars and 15 to 30 seconds in case of the primary teeth, which require more etching time. Next, we rinse well with an air water spray for 30 seconds, followed by drying the tooth surface for 15 seconds with uncontaminated compressed air. If cotton roll isolation has been used, we have to, at this point, we will have to replace the cotton rolls. Then we see a frosted white opaque appearance on of the tooth. This is because 5 mm to 10 mm of the original surface is removed. If the surface becomes contaminated, re-etching is must. Next step is the sealant placement and the curing. We apply sealant, allow it to flow into the pit and fissures. In mandibular teeth, we apply sealant to the distal aspect and we allow it to flow mesially. In maxillary teeth, the sealant should be applied to the mesial aspect and allowed to flow distally. Any kind of air bubbles should not be incorporated, and hence we should be careful about that. Step 5 is the curing. 10 to 20 seconds of curing is required, and the exposure is to the visible light. The tip of the curing light should be held 3 mm to 5 mm from the surface of the sealant. Step 6 is the evaluation of the sealant. This is done both visually and by tactile sensation. We take the explorer to attempt a dislodge, and if it's not able to dislodge, that means the sealant is in place. Step 7 is to evaluate the occlusal sealant. Occlusal high points should be assessed well. We check the occlusion with articulating paper, and we finish it off with round finishing burr if required. If not done well, 15 seconds of etching should be repeated, and we repeat the whole procedure of placement and curing of the sealant. Now to conclude, I would like to say that pit and fissure surfaces are at greater caries risk than smooth surfaces of both primary and permanent teeth. Sealants are primarily used to prevent tooth decay in pits and fissures. It can be assumed that they are most effective in populations in which smooth surface tooth decay is under control. Because the majority of tooth decay occurs on the occlusal surface, sealants are one of the most important measures available in the prevention of tooth decay. So, we as pediatric dentists like to advise the use of pit and fissure sealants in all patients with deep pits and fissures. In the end, I would like to thank you all for your patient listening. Thank you.